Bienvenidos al webinar por el Día Mundial de la Salud, Mi Salud, Mi Derecho. Este webinar está siendo transmitido en nuestras redes de Facebook y YouTube del Organismo Andino de Salud, Convenio Hipólito Unanue. También estamos en esta fecha especial por el Día Mundial de la Salud de manera presencial desde la Secretaría General de la Comunidad Andina. A continuación, tenemos la palabra de bienvenida a cargo del embajador Gonzalo Gutiérrez, secretario general de la Comunidad Andina.
Muy buenos días a todos, señor viceministro de Prestaciones y Aseguramiento de Salud, señor Ciro Mestas, señor viceministro de Salud Pública, Ricardo Peña, querida amiga secretaria ejecutiva del ORAS, el convenio Hipólito Unanue, doctora María Carmen Calle, señores miembros de las embajadas, funcionarios, amigos, sean todos pues muy bienvenidos aquí a la Secretaría General de la Comunidad Andina. En esta ocasión, el webinar que vamos a seguir conmemora el Día Mundial de la Salud. Este es un día que se celebra cada 7 de abril de cada año y recuerda el establecimiento de la Organización Mundial de la Salud. Hace ya 76 años, en 1948, fue que sesionó por primera vez. Y yo quería recordar 2 o 3 elementos históricos de la OMS. En primer lugar, que la iniciativa de tener un organismo que se ocupase de los temas de salud provino de 2 países, de regiones muy diferentes, China y Brasil. Y esa iniciativa de estos 2 países, en el marco del Consejo Económico y Social de Naciones Unidas, fue acogido. Y así nace, en primera instancia, la Organización Mundial de la Salud, que sesiona por primera vez en Ginebra, en Suiza, en 1948. El objetivo inicial y que se mantiene hasta la actualidad de la OMS es el promover la salud como un derecho humano. En este Día Mundial de la Salud 2024, el lema elegido es Mi salud, mi derecho. Y es muy emblemático porque significa la necesidad de defender el derecho de todos a tener un acceso abierto, directo a la salud, a la educación, a la información de salud, pero no solamente ahí, no se agota en eso, también es en el derecho a tener agua potable, aire limpio, buena nutrición, vivienda de calidad, condiciones ambientales y de trabajo decentes y que sean también libres de discriminación. Debemos decir, constatar que el derecho a la salud alrededor del mundo cada vez está siendo más amenazado. No estamos en una tendencia que es importante revertir. Y este riesgo que estamos enfrentando en materia de salud tiene diversos orígenes. Y estos orígenes principalmente están vinculados a los fenómenos medioambientales que estamos sufriendo. El cambio climático,
change, the loss and abuse of biodiversity, as well as contamination and pollution, which is most prevailing. And in spite of the notable advances and breakthroughs of medical science, and I think the proof of this has been the speed in which technology was able to prepare a vaccine against COVID. So now I think more or less everybody, we have gotten a vaccine, following the instructions I have my 6 shots, the bivalent and the booster shot, and I think this is something that we should all have and do. But the speed in which the vaccine was developed. Since the first few days of the pandemic until we got an actual vaccine that worked is notable, and it's outstanding. And for me, that sheds some light on this, that creates hope that technology and science will be able to help us to fight against these threats that are more and more prevailing each time. Millions of people, like I said, still do not have access to quality and essential health services. And this is mainly based and due to social economical factors and systemic disparities that we have to fight against and overcome. Today, and this day, the World Health Day, I think also reivindicates something that is very important for countries like the Andean countries, which is multilateralism and the importance of having multilateral work to develop initiatives and to reinforce our international positions. I just wanted to say that precisely yesterday, I was in a work meeting with some officers here at the Secretariat of the CAN, the Andean Community of Nations, because we're developing an initiative to create a South American Center for information and training to combat eventual future pandemics. So I think this is quite a very important piece of news. And here in this region in Latin America, the fact that we could have a center, a research center that will be able to train the different countries, so, basically the members of Mercosur, and the Andean countries, so that in this region we can create capacity building and have more trained human resources and the development resources to actually fight future pandemics. Hopefully it won't happen, but any future pandemic that could affect us. I think this is a trend that really is important. This COVID-19 pandemic showed us how unarmed and how we were caught off guard in Latin America as a whole to face this kind of crisis. So I really, really hope that in a short time, this initiative will actually become a reality. And just to wrap up with my comments, I would like to thank you for your presence and again, your in-person presence and your online presence, because I do believe that the topics that will be dealt with in this webinar are of utmost importance, will help us reflect and see how we can actually continue generating this push. And to talk about health as a human right, we all have the right to that. Thank you very much. Thank you, Mr. Ambassador Gonzalo Gutierrez. Next, Dr. María del Carmen Calle Dávila, Executive Secretary of Horas CONU, to give her opening remarks. Good morning, good afternoon, good evening, depending on where you are. I also have to say that this webinar has simultaneous interpretation into English. So we also have the Caribbean countries and some European countries that are logged in today. The World Health Day, which is commemorated every April 7th, to commemorate the anniversary of the foundation of the WHO, the World Health Organization, which was in 1948. Every year focuses on a concrete public health issue. In 2024, the World Health Day has as a motto, "My health, my right." And this highlights the fundamental principle that health is a basic human right, irrespective of the socio-economic status, ethnicity, sex, gender, geographical location. Every single person deserves equal access to health services. equal access to preventive measures and essential medication. This motto also highlights the urgent need of addressing the disparities in terms of health, ensuring equal access to healthcare, and train people for them to take over the control of their own health. During these times, and also exacerbated by the coronavirus crisis having affected most of the world, to celebrate and commemorate the World Health Day is actually a really important and valuable mission. The health of our planet is at risk because of several reasons, all of them and there are factors that affect directly the health of people, and the Secretary General already mentioned this. We're talking about climate change, the loss of biodiversity, and pollution. But also, I should say that conflicts should be taken into account, because conflict also decimate lives and they cause death, pain, hunger, violence, and psychological stress. As a consequence, in order to protect health, there have to be actions taken from the different sectors. I, of course, don't know since when we talk about, multi-sectorial, it's been decades talking about multi-sectoriality, but then also we need actions at the three levels of government in order to defend everyone's right everywhere to have access to health services, education, and information, as well as safe drinking water, clean air, good nutrition, quality housing, decent working and environmental conditions, and freedom from discrimination. The human rights, as we all know, are universal rights, and they pertain to every single human being, irrespective of their race, gender, language, religion, political opinion, nationality, social status, economic position, place of birth, or any other condition. Every single human being has a right to the highest possible care of physical health and mental health. But for that, countries should develop and implement policies and laws that will ensure universal access to quality healthcare and services, and that would address the root causes of the disparities in health, included among them poverty, stigmatization, and discrimination. The right to health is indivisible from other human rights, included among them the right to education, participation, nutrition, housing, employment, and information. A rights-based approach require to incorporate principles and fundamental standards of human rights in all of the healthcare services that are provided, and in all of the policies that the health system has, included the development and the responses to emergency and public health. The right to health include four elements, four key, essential, and interrelated elements. We're talking about availability, accessibility, acceptability, and quality. So the motto, my health, my right, really only reaffirms our commitment to the promotion of health equality, promotion of the universal access to healthcare, and training of people to exercise their right to health. By dealing with the systemic inequalities, the promotion of education and awareness raising, the usage of technological breakthroughs, and having integrating health systems, we can create a world where every single person can enjoy their inherent right to health and well-being. The ORASCONU knows and has clarity in terms of their commitment to the right of health. And this is reflected on the vision of the strategic plan 2030. The vision says that by 2030, the inhabitants of the Andean region enjoy the right to health and well-being. The inequalities have been reduced, and there is a greater response capacity to the different health challenges, social, economic, and environmental challenges that are common to the region by means of integration and regional cooperation. So in this context, we will address this topic, my health, my right, from different perspectives. And for that, we have the participation of key authorities and relevant authorities in terms of health, both nationally and regionally, as Dr. Yarbas Barbosa da Silva Jr., the director of PAHO, Dr. Ciro Mestas Valero, Vice Minister of Health Provisions and Insurance from Minsa, Peru, Dr. Eric Peña Sanchez, Vice Minister of Public Health of the Ministry of Health in Peru. We would like to also express our gratitude to them. We also thank the Secretary General of the Andean Community of Nations that allowed us to be here today. We have quite an important relationship in terms of health. So we also would like to congratulate the creation of this research center and training center, because that's the idea. The idea is to really look at health sovereignty. We cannot be waiting and depending on other countries and relying on other countries to do things faster and better. So welcome everybody to this webinar. Thank you very much, Dr. Calle. Next, for his opening words, we would like to invite Dr. Ciro Mestas, Vice Minister of Provisions and Insurance of the Ministry of Health in Peru. Dr. Mari Carmen Calle, Dr. Gonzalo Gutiérrez, Dr. Peña, dear Minister of Health and Vice Minister of Health, I would like to greet you on behalf of Minister Dr. Cesar Vázquez. And to talk about the World Health Day is to talk about not only those of us who are part of the Andean Community of Nations, but we're talking about the planet. We are in a new context. There's climate change that completely changes the conditions of life and therefore the conditions of health of people. The productivity of the different territories also, and therefore the productivity conditions and the lifestyle of people. We also have the immigration condition. We have conflicts, or you name it. We are human, and of course, from the beginning of humanity, we have been walking on this earth, and that's why the Andean countries are so rich and they are multicultural and they are diverse in terms of ethnicity. And in Peru, Peru is considered as the country where all the bloods mix, and this is a result of this mixed history that we've had, but this also affects the conditions of health of people. We are at a point where we are also having epidemiological transition, and the types of diseases that we have, different lifestyles, and so we have new challenges coming up. And all of these challenges, of course, need to see how do we ensure the right to health. And the right to health, not only in terms of access, but also, as the WHO says, it's the right to enjoy the best level possible of healthcare. And this is completely necessary. We need to do it today with what we have. We cannot wait for other conditions to occur, like having better budget, better political situation. No, we need to do it today. And the Andean countries have a responsibility, of course, in this new context, because we have climate change, conflict, immigration within and among the Andean countries. We have two important terms. We have the highest freshwater reserve in the planet, which is in the Andes. And secondly, we also have the highest and the largest rainforest, which is the lung of the planet. So health of people living in the Andes and living in the rainforest, in the Amazon rainforest, it's not a matter of just one country, and it's not a responsibility of one country, but this is a responsibility, it's a global responsibility. And all of these populations that for centuries have been unfavored, neglected because of their inaccessibility and their scatteredness, these are the ones that are actually preserving the environment the best. They are preserving these huge water resources and oxygen resources and reserves. Therefore, it's a global responsibility. And in the World Health Day, we need to think of these underserved populations. It is a responsibility that the countries have taken on, Andean countries and Amazonic countries. But like I say, this is a global responsibility. And that's why we are speaking up. We are raising awareness among the international community. We are conducting webinars like this, and we have forum like the ones conducted in APEC and also at the United Nations and the WHO and Economic Forum, World Economic Forum, because it's not only about health, it's the integral development of mankind. Again, thank you on behalf of the minister. Thank you for the invitation, and we're going to keep on working for the health of the planet. Thank you very much. Thank you very much. Next, we have Dr. Eric Ricardo, Vice Minister of Public Health from the Ministry of Health in Peru. Mr. Ambassador Gonzalo Gutierrez, General Secretary of the Andean Community of Nations, Dr. María del Carmen Calle Dávila, Executive Secretary of Orasconu, Dr. Ciro Mestas, Vice Minister of Public Health, Health Provisions, and distinguished guests, and also greetings to all of the participants who are connected online. I also would like to again reiterate the official greetings by Dr. Cesar, by the Minister of Health. And I think that the people who spoke before me have mentioned everything that I wanted to share, and the emphasis on the importance of and commemorating the World Health Day, and the topic that this year was chosen, which is my health, my right. And so this is highly relevant because, as was mentioned before, the current context and the situation, post-pandemic situation, represents a completely different scenario where there's threats, where there's global threats that put this at risk. So all of the efforts that the different countries are developing, and precisely, in response to go back to health as a human right. But all of these, it has to be grounded on reality. I was looking at some of the data from the WHO about this day, and I was reading that between 100 and among the 194 members of the WHO, out of 194, 140 include in their constitutions health as a right, as a human right. However, if you actually do a more detailed analysis and you see actually how much this is actually practiced in reality, how much this is actually translated into a legal framework that is applicable and that will result in concrete actions to really have a universal access to healthcare that will ensure everybody a dignified life and a decent life. This really, in many of these countries, this doesn't happen. And there's big nuances and differences between the different countries. And also, some of these are influenced, of course, by all of these external factors that are posing a threat, like wars and enforced displacement, refugee status, and climate change. And in the presentation, we're going to talk about, what this implies and what this implies for the well-being of mankind, and maybe we can have some affirmations and some statements. But I just wanted to say this because I do believe it is important to always have these in mind. And I think that the fundamental objective of this day and the commemoration of the World Health Day is to increase and enhance the perception of people and of mankind in general, including governments and including decision makers, about the need of reorienting our initiatives and trying to land all of these into concrete actions that will lead us to have a positive effect on people, and that will actually push well-being for everybody without leaving anybody behind. So these are just a few words that I wanted to share with you. I'm quite grateful and thankful for the organizers of this event, to all the participants. Thank you also, and those of you who are here and online. And I really hope that each one of you not only will actually, think and reflect, but also wherever we work, wherever we are, really that we try to work towards reinforcing our actions so that we can reach common goals and trying to look at ensuring health as a human right. Thank you very much. Thank you very much, Dr. Peña Sanchez. Now we would like to take an official picture. If you can please stand up. We would also like to greet the presence here today of Dr. Aníbal Velázquez, former Minister of Health, also Dr. Sarah Lawton, representative of the World Food Program, and also Marilu Chan, Director of Prisma, Dr. Irma Ramos, Director of Impares, Dr. Jorge Martin, Delegate of the International Organization for Migration. Also with us, we have Dr. Cesar Cabezas from the National Institute of Health, Dr. Maria Elena Ugaz from UNICEF, Dr. Magali Escate from UNICEF also joining us. Thank you for your presence in this room. Dr. Yuli Caballero, Director of Mental Health of the Ministry of Health of Peru. Also, we would like to greet Federico Arnilla, Chair of the Roundtable and Task Force on Poverty. Also, Dr. Mercedes Arevalo, President of the National Peruvian Society of Adolescents and Youth, and also the technical team and administrative team of Orasconu. Thank you for being here. Next, I would like to give the floor to Dr. Marisela Malki, Deputy Secretary of the Orasconu, to moderate this webinar. Thank you very much, Janet. Let's remember that we are in a hybrid webinar, so we are going to try to go back to the online format sometimes and in person. So after the formal opening of this webinar, again, welcome to everyone to everyone who is here today with us and online. It's been almost 4 years since Horas Conu started having these webinars. It was, in next May, it will be 4 years exactly. And this we did in order to have continuous learning. And today, Thursday, April 4th, we are commemorating the World Health Day a few days ahead of its actual date. And this year, as was mentioned, is My Health, My Right, highlighting the importance of ensuring universal access to healthcare services, education, and other services in a world where the inequalities and disparities in health are still a challenge. So it is key to recognize health is a fundamental human right. Positive peace is defined as structures and institutions that create and maintain peaceful societies, and it is essential for the well-being and the health of people, because it allows for the rights to be respected and to take advantage of their skills. That's why at Horas Conu, we promote health as a bridge for peace. Boys, girls, and adolescents are not the future. They are the present. Whatever we do now will actually have an impact on their well-being to contribute to social justice, environmental justice that Horas Conu is always seeking. So reflections about these and other priorities for health and well-being you can find them on the Notisalud Andina's newsletter. We issue this monthly. You can look for it on our website. And well, everybody who is joining online, we would like to also remind you that you can drop your name, the organization, and the country where you are joining in the chat box of the Facebook and YouTube Live. And then in that same space, you can write your questions, or you can email them through horasconu@gmail.com. And in order to have access to your certificate of participation to this webinar, as usual, you have to fill out a very brief survey and then drop your information on the link that you will find in the chat box of YouTube and Facebook Live. So please make sure that your email is correctly written so that you can get your certificate. Well, this webinar, this presentation will be done as usual. We already started with the official greetings, and now we're going to have the keynote speech, and then we will have a Q&A for, about anything that is mentioned today. So after this, I will introduce myself. My name is Marisela Malki. Well, Janet already mentioned this, but I will be moderating this webinar. And this is a hybrid format. And now in this this is in person. We have the presence of different public officials and embassy representatives and the whole team of Horas Conu. This is great. And so today we are going to start with a video that was sent by Dr. Jarbas Barbosa da Silva Jr., director of the Pan American Health Organization, PAHO, as a way to participate in this webinar today. He was not able to actually log in live, but he was kind enough to send a pre-recorded video of him giving a few words. So please roll the video. Thank you very much for the invitation of Horas Conu to participate in this webinar in commemoration of the World Health Day. Greetings to the authorities and the different authorities from Colombia, Ecuador, Peru, and Venezuela. This year, we commemorate World Health Day, and the motto is My Health, My Right. In 1948, the World Health Organization
sin discriminación alguna. Sin embargo, en la región existen poblaciones que experimentan dificultades para acceder a los servicios de salud debido a la discriminación y a barreras financieras, geográficas, culturales, lingüísticas y de accesibilidad. En la Organización Panamericana de la Salud, trabajamos con nuestros Estados miembros en la garantía de ese derecho a la salud para avanzar hacia la salud universal para todas las personas, incluyendo a las poblaciones en particulares situaciones de vulnerabilidad. Esto inclui el acceso oportuno a servicios de salud de calidad y apropiados, sin discriminación alguna. Não pode ser mirado como um privilégio, sino como um direito humano. Deste modo, o direito à saúde é indivisível e interdependiente de outros direitos humanos. Os instrumentos internacionais de direitos humanos, tanto das Nações Unidas como do sistema interamericano, servem como marco legal e conceptual unificador para melhorar a equidade em saúde e desenvolver estratégias e aproximações contra a discriminação, a estigmatização e a exclusão. A região de las Américas está afetada por las desigualdades históricas entre os países e dentro de ellos, exacerbadas durante a pandemia de Covid-19. As condições socioeconômicas, como a pobreza e o acesso limitado à água potável, ao saneamento e aos alimentos saludáveis, expõem as pessoas e as comunidades a maiores riscos de enfermidade. Estes contextos implicam ou exacerbam situações de vulneração do direito à saúde e outros direitos humanos de milhões de pessoas em las Américas. A OPS tem um compromisso histórico de expandir o acesso equitativo à saúde em toda a região. A organização continua avançando em implementar a agenda de eliminação de enfermidades transmissíveis e enfrentar as enfermidades não transmissíveis, assim como o fortalecimento de serviços de saúde com a introdução de inovação e tecnologias que possam responder melhor e de forma mais equitativa ante atuais e futuras ameaças. Desde há anos, OPS e Horas Cono são aliados estratégicos em saúde pública en el âmbito da região andina. Me gostaria de recordar que a região andina ha sido pioneira em iniciativas e propostas que han logrado escalar, incluso a nível global, como a Semana de Vacunação em las Américas, que agora é uma estratégia global. Muestra del trabalho conjunto entre Horas Cono e OPS é a reciente renovação do Acordo Marco de Cooperação Técnica, suscrita em setembro do ano passado, e que dá um novo vigor a esse mecanismo a nível subregional para articular a cooperação técnica com a OPS e a nível horizontal entre países da região. Me permito destacar algumas das experiências exitosas que demonstram o potencial de estes mecanismos. Desarrollo del Curso Andino de Clima e Saúde para o fortalecimento de capacidades do recurso humano andino com enfoque nos ministérios de saúde. Visitas técnicas de los ministérios para conhecer experiências significativas de saúde e câmbio climático, assim como a elaboração conjunta de um projeto regional sobre saúde, ambiente e câmbio climático. Em la subregião andina, o câncer infantil é a primeira causa de morte por enfermidades não transmissíveis em la niñez. Frente a essa problemática e com o decidido acompanhamento da organização, se hizo efetiva a campanha Detectemos el Câncer Infantil Hoy, enmarcada por el projeto de detecção precoce de câncer em la niñez e adolescência em la subregião andina. Essa foi uma proposta do Comitê Andino de Câncer, del Horas Cono e OPS. Se han produzido materiais multimídia para apoiar a las autoridades de saúde em la advocacia e sensibilização sobre câncer infantil, com mensagens para promover a detecção oportuna, com um enfoque intercultural e adaptado ao entorno local. Ao celebrar o Dia Mundial de la Salud, a OPS reitera seu compromisso para que todas as pessoas de nossa região, os niños, las niñas, as pessoas adolescentes, homens e mulheres, sem discriminação alguma por sua origem étnico ou racial, orientação sexual ou identidade de gênero, classe social, posição socioeconômica, idioma, condição de pessoa migrante, situação de discapacidade ou qualquer outra condição, possam efetivamente dizer: mi salud não é um privilégio, es mi derecho.
Mensaje con
Well,
énfasis
this was a great message with an emphasis on advocating for the rights and the access to the rights of health, drinking water, clean air, housing, decent working conditions, environmental conditions, and this and free from discrimination. I also want to take advantage of this moment to greet Mr. Melquiades Heredia from the Embassy of Bolivia and Mr. Ivan Trujillo from the Embassy of Colombia, who are also joining us today. Next, we will give the floor to Dr. Ciro Belmesta Valero. He is a surgeon and a PhD on biomedical engineering by Universidad de Campinas, Brazil, a master's degree in economy, project assessment for development. He also has different complementary postgraduate studies, medical auditing, etc. University professor, researcher with a vast experience at the different levels of government. And as we know, he's a current Vice Minister of Provisions and in Health. Thank you very much. Do we have the presentation? Well, but we will start talking about the right to health. And we also need to make a differentiation, which is right to health is not only access, but right to health, it's actually to enjoy good health. And this is a result of all of the provisions and benefits and enjoying good quality of life and lifestyles. So some countries have defined the right to health as a right to access healthcare services, but it's not only access, it's also to have these benefits and provisions, and it's not only being a user of the services, but it's actually enjoying the benefits and that the person will enjoy the best conditions of life. But Dr. Calle, during her introductory comments, already talked about the right of health, and I don't really have to add much more. But what I will do is to say maybe how we can do this. And to do that, there's challenges and perspectives about the about the activities and the actions that we can conduct. Well, this slide, we've seen it many times because several of the Andean countries and the countries around the world already have ensured universal access, but the new challenge now is universal coverage and what we need to do. And that's what I will talk about. Maybe not of all of the things, but the easiest things to do and the main ones. Countries have fragmented healthcare systems, and really the exchange of the different service provisions, really it has not worked correctly. So the challenge is how can we interoperate all of these healthcare systems? And in order to interoperate for the healthcare systems to work, it is key for the healthcare systems to actually have information systems that are patient focused, that are centered on patient care, not so much on the interests of that who manage and those who manage the system. And then, of course, there's money needed, there's resources. Anything that is health related, it costs. And even in the best, in the best economies in the world, the resources of health are always insufficient. And the economy of health says that in health, the supply creates demand, and there's increasing needs in health that need to be funded in order to meet those needs. So of course we need to go from the budget and the situation to finances, and for that of course we have different strategies, we have new mechanisms, new payment mechanisms, we have new strategies, new funding strategies, and then also new responsible people, because health is not only of the healthcare system, as was mentioned here also, it is also nutrition and food. And if we talk about food, in order to have good a citizen that is well fed, we need good agriculture and good, livestock. And so we need to think about one health, and we need to get the productive apparatus engaged also to ensure health of people, because having good health and enjoying good health, it's not just having access. And in order to do that, the person has to be well fed, has to be well nourished throughout their life. We're not just talking about cycles of life, because we don't go back to the cycles, no, but we are talking about before conception all the way till the end of our days. And that's why, we have also social security, and that is a good tool because it stimulates payment mechanisms so that the service provisions can be more efficient and more effective. And it's fundamental, especially right after the pandemic, that to understand that we need to look at microorganisms locally, not only, of course, dominate them and create vaccines, but also we need to look at developing efficient antibiotics and technology that will give us a response to adverse situations. We just went through a pandemic, and it could go back anytime with any other organism, and a variation of the same organism. And that's why we need to have technologies and vaccines. And and I'm talking about locally sourced and locally produced, because the right to health is also eliminating inequalities. It also means eliminating inequalities. And, in the post-pandemic era, we have seen how unequal the distribution of vaccines was, and how unequal and how big the gaps are in terms of underserved population, like some specific ethnical groups. And the same thing can happen. And the lessons learned from the pandemic, I think, are forgetting them real quick. And so this is the idea, that I want to share, that we need to remember the lessons learned. That's why it is important to really master technologies. And the Andean countries during the pandemic, we really had very little local production, very little production of vaccines, and you need to remember about the oxygen issue. And it's not only technology, it's not only producing the oxygen, but how to actually trade it and sell it, and how to have a logistics chain and a distribution chain. So it's all part of this. Something key, citizen participation also. And citizen participation is not only the right to enjoy good health, but if we're talking about the right, like the right to health, we also need to talk about a duty, because there's no rights without duties. And it is also the citizens' duty to make sure they have good health. That's why we need to promote self-care and co-responsibility in health. And this, I bring this up because Dr. Edith Munoz during planning of actions, she's always reminding us that it's not only a right, but it's also a duty. Self-care is a duty of citizens, but a citizen who is not well informed cannot really make good decisions and sound decisions. Therefore, we need to have education in health in order to exercise our rights, but also to fulfill our duties. And then, Dr. Calle, you were talking about intersectoriality, but I will talk about transsectoriality. Health is a duty, and all of the sectors of the government and the private sector and the industry and everybody need to support this work. We need to go from intergovernmental relations, vertical relations in the national and local governments. We have to go to an intersectoriality that is permanent between these different levels of government. We also have the participation of other fundamental sectors, agriculture, livestock, housing, because there's no health if you don't have safe water for population, for instance. Also, defense, economy, trade, all of these that has to go very well aligned with health. International relations in a country or in a planet, better yet, where diseases travel and the lifestyles are being copied. So it is important, of course, to have intergovernmental relations that are sound and safe at every level. And it is key. Those of us who are working in the healthcare sector, we need to follow the principles of, first of all, not harming anyone. And that's why it is important to work ethically and responsibly, especially when it comes to the financial resources. If there were no mismanagement in the healthcare system, I think that resources will be enough if they are not badly spent. And so I'm saying this just, in a very graphic way. Healthcare systems and information systems in health, they need to be focused on the person. They need to be patient-centered. All of the administrative systems, and not as the figure shows, that the healthcare systems have organized their information system based on their interests. There are information systems and, logistical work for medications and for finances. And they are based on the interests and the needs of the managers of, health facilities and medical staff and human resources and insurance companies. Each one of them, and they have their own system of work that is based and centered on their interests. And I think what we should do is to change that rationale and to flip it around. We need to have the citizen at the core, the person at the core. And then all of the information systems and financial systems need to revolve around that person and looking after that person and managing the care. And all of that will then result in meeting the needs also of the manager, the technology manager, the healthcare manager, the financial manager, family medicine, etc. And then I think we need to also be financially smart, because just the way the healthcare systems are working in the world, especially in the Andean communities, so the numbers won't work if we want to really take care of the patients when they are sick. But the numbers won't work if with the mechanisms that we have right now. It's not going to be enough. So I think we need to have to be financially smart. We need to be creative. And this is taken, from English, but we need to do it. We need smart finances. They need to be smart, meaning specific, measurable, adjustable, realistic, and time-oriented. We need to work with whatever we have now, but we need to have specific goals. And then all of these need to be measurable. And if we don't measure our objectives in the short, medium, and long term, we won't really know if we are making progress. And then they have to also be realistic, based on what can be done. We should not have unrealistic goals. We need to adjust to our realities. And therefore, it has to be realistic. Finances have to be realistic. And they need to be also time oriented. They need to be timely. They need to have deadlines. And so we have to go from any financial system that we have right now in the countries to financial and smart goals. And this is basic. And so, of course, for this, we need the change management, especially for information system. And so, just like we had change management in transportation, we have, this was transportation for a while, the carriages, the horses, and we had this before. And so this was an analogy when, the first car appeared, the 4T, in the world, there were winners and losers, but the one who actually won was the passenger. It was faster and better, and there had to be a change in the rules and the routes. And so we actually got to this today without a huge technology change. So here people needed to change and accept new technologies. And in health, we need to do the same thing. And so it's information in health from the moment the information is created. And unfortunately, in many parts of the world, the information is being done on paper still, manually. And in order to manage this in our realities, we need to convert that into digitalized information. And in order to do that, we of course have to, waste time. We have errors in transcription, and we can really not make timely decisions because this is a world that is ever changing and it's so fast. Epidemics travel also. They travel in train and plane because they travel with people, with the patients. And the COVID-19 pandemic taught us exactly that. Vectors also travel, and vectors can now go in a car, and you don't have to really know if it actually flies 200 or 400 meters. They actually travel between provinces, between regions, and even internationally. So if the data is created on paper and they are transcribed and they are not structured data, then of course we're going to lose. Just like we have cemetery of papers, we will also have digital cemeteries, but we need structured data that can be seen in any computer, anywhere, because any computer, anything like you have in your pockets, your smartphones, it has a greater processing capacity than the computer that helped men to reach the moon, if you know that. So I think we already have the resources. We do not have to reinvent the wheel. The engineering problem is key, and now we have the semantics. And so how to do this? We need to structure data based on international interoperability structures and to have the health in the world. It has to be dealt by the whole world. We from the Andean countries, we go to Europe and to the United States to train and to be better and to learn more. And the citizens of the most developed countries in the Northern Hemisphere, sometimes they come to the Andean countries to see and to think, okay, how did they build this empires? How did the Inca Empire build Machu Picchu, or how did they created the Nazca lines, and and they can also get sick here or bring diseases. So therefore, all of these, they have to be created on structured data. So I would propose today on the Health World Day that the data in health, they have to be created with global interoperability standards, because the citizens now are citizens of the world. And and in my office, we have proposed Horas Conu we have proposed from Horas Conu to have interoperability standards. Sometimes between the countries, it has been impossible, not even within the subsystems. Otherwise, you can see how data is managed within the ministries of health of different countries, epidemiology and all the clinical data, how the medical records are created with free text. So we are in the 21st century. We do not deserve that. We do not, we don't need carriage and horses. We need something that is faster and better. We need to go from the carriage to cars, as you see now. Whichever model you like, but it has to have the same rules, the same standards and speed standards. So let's go from that first computer that you see to the current ones. So the engineering issue, I think, is already sorted out. We have a semantic problem of data in health. So life in data, it's as it is shown here. This is the actual real life. In order to make decisions, what we need to do is to structure data. We need to classify data. And if we classify data, and if we actually put them in a geographical context, we will have this data and evidence that is created at the point of care to make decisions as a country, as a region, and especially locally too, because it cannot be that workers in health that produce data, they don't have data to make decisions locally. They don't. It's impossible that citizens cannot see the information that they produce, because citizenship also means to be informed and to know what is being done locally and regionally in terms of health. And that is part of really exercising the right to health, to be informed, to really know what is happening in the community. So we have talked much about this in the region, and we always see the health establishment as key, and the entity that provides healthcare services, whatever name you want to give it, the health facilities. But how do these health facilities be? They should also be smarter. They should also be health establishments that are completely digitalized. And this digitalization, it has to be standardized, as I already said, based on international standards. This will also reduce inequalities, because inequalities in health already exist. But if you see it maybe based on the race or economic situation or the region of the world that you live, the gaps become an abyss. So we need to actually have more equality and not in the sense of providing the same to everyone without regarding their context, but actually giving more to the one who need the most. Health facilities should be innovative and resilient, because the smaller ones are the ones that in the region, at least proportionally, get the least funding. They get the least technological innovation. We were briefly assessing about the biomedical technology at the different levels, and there are gaps, yes, but if there's third level care or the most complete hospitals, they maybe are implemented at a 70%. The hospitals like the regional hospitals or district hospitals, they have a 70% gap, but the smaller health facilities are actually at a 17%. This means that for decades they have less and less devices. They don't have scales, they don't have pressure cuffs, or all of these medical devices. And so if we really want global health to actually occur and for systems to be resilient, we need to implement these strategies. We need to have basic technologies to all of the health facilities that are closer to the citizens. If we do this, we will actually realize access to health of the most underserved, and therefore health facilities will be more efficient. They have to be accessible and integral. And when I'm talking about accessibility, it's not about having establishment that it is closer and closer to people, but it's just having everything that people need: the social benefits, education for health. What the state does in promoting agriculture, it has to be closer to a health facility, or actually part of the facility. So we need to completely change this rationale. They should not be health facilities. They should become comprehensive health facilities. So they actually have to be promoting the integral development of the people. If we're talking about our countries, they have to be also sustainable. They need to be environmentally friendly. And therefore, they need to be adapted to this population, and they also have to be intercultural, because we're not going to give, the same nutrition to someone in the Western world, to someone who is in the Amazon region, for instance. So if we do that, we will actually have a more universal healthcare system, more equitable, with citizen participation, and also decentralized. This is what we can this is what I can say, what we can do so that we exert the right to health. And then I'm really sure, and I'm sure that Orasconu and the different international organizations and financial entities will help us to achieve this. Thank you very much. Thank you, Dr. Mestas, for his great presentation. He has actually talked about the fact that this a right to health is not just access, but also to the maximum level of well-being, and we need to go from just universal access to universal coverage. He talked about exchange of information and interoperability, and the data already have to be created with these standards. Thank you, Dr. Messes, for your excellent presentation. Next, we are going to give the floor to Dr. Eric Peña Sanchez. He's a surgeon and epidemiologist. He actually has worked on interventions on public health and primary care. He has an experience in the development and implementation of control interventions of non-communicable diseases and specialized technical assistance for the assessment of epidemiological risk. He's currently the Vice Minister of Public Health at the Ministry of Health in Peru. Welcome, Dr. Peña. Thank you very much. So in the first slide, I had included in the first slide, this is an article that was published in Lancet in 2017, and there was a framework presented on how could the two spheres of well-being be assessed in terms of the social foundation and the ecological ceiling, and how these two spheres interact, if there is an interdependence between the different dimensions of health, or the factors that directly influence health in the social sphere. And here we even have the health systems. And then also when we talk about the ecological sphere, and then you see here the factors that have an action directly on human health and on the concept of well-being, and also how this has to do with the environment. So we have climate change and issues like usage of soils and reconversion of soils, acidification of oceans, etc. So there's a series of factors that have actually make today's scenario to be completely different. And so it requires a completely different response for the health services. And so if we want to understand health as a right, we need to start based on the promise that well-being can be gotten only if we have a healthy life, a healthy person, and that this person has to do this. And so we need to make sure, importantly, throughout the life, and also based on the standpoint of public health. This is what we want, exactly. We want to look at interventions that deal with collective health, and that precisely consider the person, the stages right after birth, and during their whole life. In the meeting, at the meeting of the Executive Committee, session 154 of the World Health Organization, the Executive Committee of the WHO that was held in January this year in Geneva, there was a document that was discussed. The document is called Economy and Health. And then on this document, there is information that is quite interesting. There's a council that the WHO created with experts, worldwide experts in economy and public health, and designing health policies, and even some government stakeholders. And they talk about the necessity of looking at health, not as a short-term expense, but actually as a long-term investment. And this is something that needs to understand, and everybody recognizes that. However, and I say this on a personal note, because certainly when I worked at a subnational government, and I was the epidemiology director at a subnational entity, I was always trying to look for, improving the interventions in order to prevent and control diseases. But sometimes we get frustrated because we demand more funding, we demand more resources, but we always have this sense that the Ministry of Finance doesn't understand the urgency of this. And now that I am on the other side, we realize the diversity and the complexity that has to do with the interaction and the decision makers. And then also on this next slide, you can see the behavior and the distribution. On the left is funding on health and the different categories of countries. It can be low income countries, low, middle, high, and high on the extreme right. And then you have the scatter plot on the right. You can see in different colors the different dots. You can see each one of the countries, and so we maybe are around here. I don't know if the laser pointer works, but no, doesn't. But we are around halfway, between the horizontal line and the upper level in blue, because Peru is considered as I'm talking about Peru, is considered as a country that has upper middle income. But we certainly are in the middle. There's other countries that have upper middle income that are way better in terms of the proportion of GDP per capita and the proportion of GDP and how much is invested in health, and about the same indicator per capita. And then this, reflection has to do with the fact that, well, sometimes, this is what we are facing now too. And I am going to talk about this when I talk about a specific disease that has been a regional issue, and it is a regional problem right now, and it has to do with investment in health. And certainly, I wanted to talk about this and discuss about this based on the initiative where we can promote capabilities and have a better response to global emergencies, because there is a huge need. I understand that, and this is at least for Peru, but probably this is a situation that is happening in other countries in different, magnitudes, but it's the need to also talk about in economic terms when it comes to health. A few years ago, there were several studies, economic studies, in terms of investing for strategic investments for non-communicable diseases. So they were estimating on the return of investment per each monetary unit that is invested in a prevention program and controlling one of these diseases. And certainly, we do have the urgent need to call for international, cooperation so that they can create multidisciplinary teams. But the idea is precisely to generating and building this capacity, because economy and health is so needed. The economics in health are needed. If you talk to the, let's say, if you talk to the Minister of Finance, and if you talk to them in economic terms, and if you say, okay, if we're going to spend this on this intervention and it will have this return on investment, well, definitely it will be an advantage and it will be understood so that we can continue. And of course, talking about timelines, etc. And this will be useful because it will not only ensure that there will be timely interventions that will benefit the population, but also it will ensure the sustainability of having this kind of interventions. And then it also goes through the fact that we need to better quantify our interventions. I think we are used to adopting strategies or interventions from other parts of the world and then implementing them without really measuring them. Now we do have significant tools like implementation research, and that really allows us to measure barriers and facilitators that respond to all of these, it responds to each context. When you have an intervention, it is not going to work in the same way if you are in the Andean region or the coastal region or the Amazon region. So we need to take that into account. We need to identify those factors that act as a barrier, as a facilitator. It will allow to have better results. And so this is what we are working on at the Ministry of Health. And I understand that we're not going to have immediate results because this needs time. Definitely, this will be shown not immediately, but this is what we are trying to, and maybe, I just want to talk about this. We need to build capacity to be able to work on this, to make progress. And this is directly connected to what we are talking about, the health as a human right. The general policy in Peru has 9 different thematic axes, and one of them, the 8th one, you can see it here, and this is the general policy. It says health as a human right. And then among this, and within this 8th thematic axis, we have 6 different aspects that guide the interventions. But again, and this is what I was talking to with Dr. Caballero before starting. She's the executive director of mental health at the ministry, and she was telling me that, because we do have all of these diseases that we're having, anemia that is hitting the country, and it has been getting worse after the pandemic. It really makes us lose a little bit of other health problems that are also important and just as important. And, if we talk about this premise, and I just want you to understand that while it is true that we have priorities on the national plan, it doesn't mean that we are not working on the others issues. We need to work on them simultaneously, but we need to always think that we need to have interventions that are aligned, not only aligned with the general policy, but also align with mechanisms that will make sure that interventions respond to the problems, and we also have the capacity to provide feedback and to change as needed. So I said that I was going to talk about 2 specific problems and in commemoration of this World Health Day. And they will actually become a really important example of the approach that we need to use. And so I have prioritized these 2 topics because if we talk about the burden of disease study that we did, communicable diseases, maternal diseases, perinatal and nutritional diseases account for still a big problem in Peru. You can see there by age group, We can see the burden of disease and in children between 0 and 4 years of age, it is the top cause of diseases. And so this this is a critical stage in child development. Again, the studies and disease burden of disease studies are a key tool to make decisions, but unfortunately in the past few years they have been very scattered. The last one was using data from 2019. Dr. Aníbal Velázquez, I remember, gave us he's the one that opened this road to conduct this kind of studies in the country, and they are critical for decision making in public health. So what we are working on now is having, funding from PRECRIS. We are going to increase the computer power for the unit that we created. And this was also with the support of funding from PRECRIS. We're going to purchase workstations so that we can actually use all of the data that comes from these studies and be able to automate using algorithms and to be able to generate the disease burden of disease, not only for this year, but if we have this computer power that we are developing, we are going to conduct a retrospective analysis, because definitely the studies of the previous years, they are actually, they have different methodologies. And so that makes it, even the comparisons are feasible, are not feasible, and we cannot do them if we do not have analyses that will actually allow us to look at the burden of disease. And maybe we don't have the capacity to infer some conclusions that are relevant for decision making. And so that's what we're doing now. We have also talked about this with Dr. Caballero, and we saw, mental health is really, really bad. But certainly this also has to do with estimation and the calculation process. But again, talking about this kind of problems that are relevant in the second semester of last year. And if we compare the different estimations that ENDE gave us in terms of anemia, we see that there has been a reduction of 1 point the second semester, but the result is completely different between the regions. If you can see this, there are regions, and you can see here on the right where the anemia rates have gone down, and there are regions that on the right are actually keep on increasing. Now, of course, you all know that in March 4th, there is a document that was published changing the cutoff points to define anemia in the world. And so with also with some recommendations, and I looked at the document, but I think the recommendations are robust in terms of the methodology and how it was used, and certainly they have used a systematic revisions, and then also using evidence that was used for the recommendations. And then certainly some of them had other recommendations, but I think, if you have all of this evidence, the decision maker can actually read this critical and make an informed decision. So I think this is the way to really use a good document. But that is going to help us face the problem. And I think the problem of anemia is multifactorial. And this is what I wanted to use as an example, because it's completely inconceivable that a child is treated at a health facility. Let's say that that he's anemic, and then they treat him, and then the patient goes back to the same environment that actually led to become anemic. So that's why the Ministry of Health created a multi-sectorial plan where we have all of the sectors that deal with anemia. And this is the result, this is the plan, and each ministry, each sector has objectives, activities, and goals that will be monitored through the work of this committee to follow up on the plan. And something that we're also changing is the way in which we're going to address anemia. All of the efforts that, well, not all of the efforts, but most of the effort that the Ministry of Health was developed, we have iron supplements and treatment with iron, and 10 to 60% of anemias, depending on the context, of course, are iron deficiency anemias. Then the remaining percentage are other types of diseases. They can be infections, they can be chronic diseases, inflammatory conditions that create iron deficiency, and then also it can be congenital diseases like thalassemias, and there's, of course, it's a smaller percentage, but they still exist. So if we look at this and thinking of the World Health Day, we want health to be a right. We need to stop thinking of health as a sole jurisdiction of the Ministry of Health. It definitely has to do with everything that every sector, with all of the factors that actually increase the probability for a person to become sick. So, I know that I've used more than 15 minutes. I was going to talk about dengue, but it's the same thing. The diseases that I picked, these are just, one mean to my end, which is to make an emphasis on how can we deal with all of these public health issues. Same thing for dengue. There has to be intergovernmental articulation and community participation, etc. But the only way of actually ensuring that our interventions in public health to have an effect is to put everyone on the table and to organize this in a coordinated manner. A week ago, last week, I was at a working group at the minister's cabinet talking about the need of having a multi-sectorial agreement for heavy metals, for instance, contamination by heavy metals. And then when we were presenting this, all of the sectors, well, I'm not going to really mention who specifically, but they didn't recognize the difference between exposed and intoxicated by heavy metal. And this is something that we all should know, everybody, because even the discourse and the communication to the population requires that everybody knows exactly what the problem is and what that creates. And certainly we are working on this. We do have the leadership and the political weight, of a minister, of course, ensures that there will be support. And so we have a great advantage now. We are working on this. And I do believe that what we are doing, and in this case, the Andean Community of Nations, it's precisely facing the problems by being as comprehensive as we can in dealing all of the factors that intervene, and to call for all the actors that have to do with having better results. And of course, to have mechanisms that will ensure a permanent evaluation of each one of the interventions through this ensuring availability and quality of information that will allow us to make informed decisions. Thank you. Thank you very much, Dr. Peña, for your excellent presentation. And you reminded us that these is not an expense, but an investment, and we really like to see that the axis number 8 of the general policy is health as a right, and also multisectoriality that is needed. We are running behind the schedule, so we're going to go faster. Next, I will introduce Dr. María del Carmen Calle Dávila. She is a pediatrician.
Con doctorado en salud pública, estudios de posgrado en universidades del país y del extranjero, como Harvard, la Católica de Chile, con especialidad en salud global por Fiocruz de Brasil, con amplia experiencia en cargos operativos, tácticos, directivos a nivel nacional e internacional. Ella ha ejercido diferentes cargos en el Ministerio de Salud. El último fue el de viceministra de Salud Pública del Ministerio de Salud en el año 2018. También fue asesora regional de salud del adolescente en la OPS Washington. Es miembro con cargos directivos en diferentes sociedades científicas, nacionales, regionales y mundiales. Y ahora es la actual secretaria ejecutiva del Organismo Andino de Salud, Convenio Hipólito Unanue. Doctora Calle, adelante, no le digo cuánto tiempo.
Marisela no me dice cuánto tiempo.
Okay, Marisela is not telling me how long do I have, because I probably will have 5 minutes. You know that everything is published. All of these presentations will be published, and of course also out of respect to the vice ministers, I cannot stay a long time. I'm going to be very quick. I will talk about the right to health, analysis of right, and what we do with the Horas Cono. I am not going to go over this. You already know about the WHO and the Declaration of the Human Rights and the general observation number 14. I just want to say that the right to health imposes 3 types of obligations. Okay, I'm not going to go one by one, but we see that in different ways, the different constitutions, all of the 6 countries recognize the right to health, recognize health as a fundamental human right. Bolivia, Chile, Colombia, Ecuador, and Venezuela are recognizing this. This is a chart that I think is great.
Solamente quiero decirles que hay una parte que me gustó mucho a mí y que era todo lo negativo, ¿no? Cuando hablamos de sistemas de salud, estamos hablando también de problemas de género, estamos hablando de problemas interculturales, estamos hablando de racismo, estamos hablando de xenofobia, estamos hablando de un montón de cosas más, pero que nunca se ponen. Y en este cuadro está muy claramente, lo van a tener al alcance. Y quiero comenzar hablando del desarrollo infantil temprano. ¿Por qué? Porque el
I want to
desarrollo
talk about early child development, because early child development is a determinant. It's determinant. It's determinant for the social well-being and the physical well-being. We should never forget about early child development when we talk about social determinants of health and determinants of health in general. I'm going really fast. I'm really sorry, but we are running behind the schedule. This is just a look at access to health services. We are talking about the social demographic index, and we say that definitely there's more access to the younger ones. I'm talking about childhood, basically from 0 to 14 years of age. They are the ones that have more access to health services. Something else is how we have been dealing with access in our countries, and definitely the country with the highest increase to access service was Peru. But it doesn't mean that this is great. You know that those who have the highest level was Chile. When we talk about 0 to 14 adults and senior citizens, we have this distribution. You have the QR there. Just and definitely health. Well, the COVID-19 pandemic has been the main factor to have a disruption in school education. 1 out of 10 countries closed their schools totally for 40 weeks during the first 2 years of the pandemic. And the consequence of this was we know that reading comprehension and all of these math understanding. This is the world map on drinking water. So we are saying that this is actually drinking water is within the place of living, not drinking water outside. Or we're talking about concrete information, but we are in yellow. This means that we are not in the best situation. So when we are talking about sanitation, it's really easy to realize the countries that are in the worst conditions. But definitely, if we realize there's while it is true there's been a bit of improvement, we're all stuck. When we talk about access to internet, at the Orasconu here, we have promoted and understood that access to internet is determinant. Definitely, in the United States, they already included it as a social determinant of health, because if you have access to internet, you then could have access to online lessons and concrete things. And then what about this? What I like about this is how many million of people do not have access, because we're always saying this the other way around, right? We always say that there's a lot of people with access, but in South America there's 80 something million they don't have access, and we're talking about over 400 million people. And a percentage have nothing. And so when they say, yes, we're going to have some communicational campaigns, but you need to remember there's a lot of people that don't have access to internet. Something else is clean air. You know that the magic number is 2.5. We're talking about particulate size matter, and we're just saying that this is our number. These are our numbers. But definitely Peru is not in the best conditions. And then the other countries are not in the best conditions either. So we're talking about clean air here. When we talk about ecological threats, I would like to invite you to use other types of indicators. We always have the indicators. And now one of the indicators that is being used is the ecological threat report.
Que son los que más amenazas ecológicas. ¿De qué estamos hablando? De inseguridad.
So we're talking about, for instance, food insecurity. And here I see the representative of the food program, and we are talking about fortified rice. And when I was a vice minister, I presented this also, and it's 2024, and we still don't have fortified rice that is accessible to everyone, because at the Orasconu, I think that has to be accessible by all, and not only for social programs. It has to be accessible for all. And there's evidence in some regions that it actually works. When we're talking about deficient access to water, please check your indicators. You know, they don't tell us how long or the quality and, you know, if they have it in home or not. Natural disasters, I won't talk much about that. And human pressure, these are all things that you know. But let's not stop thinking about the threats, ecological threats. And then something else that's also very important is discrimination, racism, and xenophobia. Here we see that it's gone down, but we do know that this has to do with their access to health always. And if we don't recognize this, then we don't know how the world is doing.
Otro hecho importante. ¿Por qué estamos hablando de paz? Ustedes dirán, ¿qué tiene que ver la paz? Bueno,
So then you will say,
posible, la paz positiva habla acerca de todas las
you have heard people talking about peace. And why peace? We are talking about the pillars of peace, and one of the most important pillars of peace is corruption. And you can see the perception of corruption that we have in our countries in this region. We're not doing great. You know, if we talk about the world, you can see the red areas, and you see the 6 countries are in red, maybe a little bit orange. The current status of early childhood, and in 2021 there was a significant variation in the countries regarding the prevalence of boys and girls that had 0 doses of vaccines. Thank you, Wendy, because when we had the meeting of the National Accord, and you included the importance of vaccines here. So definitely we have a big issue with vaccines, and definitely this is not being solved. And then there is a total of 2.4 billion boys and girls who have 0 doses or that are under-vaccinated. Then here, this is maybe, I will go to more concrete information. The poorest have 3 times more probabilities of having 0 doses than, well, this we know, it's part of inequality. And then, here we have clear numbers of prevalence, food insecurity, and the number of people that are undernourished and that are actually having severe food insecurity. Please, you need to look at the numbers. I always say that percentages sometimes are fooling us. And so if we say, so just like we talk about percentages, we need to talk about absolute numbers as well. And here, this is something that is difficult, is that we have 2.4 million people that are suffering from food insecurity that goes from moderate to severe. So we're not talking about 500,000, we're talking about 2.4 million. And I see Maria Elena Ugaz, let's not forget about malnourishment, acute malnourishment and stunting, because this one has an increasing percentage in the country. And of course, this is what's happening, but stunting is a problem. In terms of housing, I won't talk much about that. Housing, of course, has to have 3 characteristics. It has to have water, it has to have certain characteristics that not everybody has. And so definitely when we look at the countries, or between the countries that don't have these, we have Andean countries. And then if we talk about crowded living spaces, and this is also something that occurred during the pandemic, we talk about crowded living spaces when we're talking about 2.5 people per room. And overcrowding, that's the definition. Overcrowding means 2.5 people per room. And you can see in the Andean countries, there's a big issue with that. And then let's not forget that the regions, let's not forget that, peri-urban areas, It is, good to look at the rural areas as well, and it's the least favored, but peri-urban areas is also.
Y a veces todo se nos va para la zona rural y no nos damos cuenta que alrededor también tenemos condiciones pésimas. Esto solamente para hablar de las condiciones laborales, 70% de los varones, ¿no? Están trabajando, 47% de las mujeres.
We have the labor conditions, men 70%, women 47%, and then to the right, also the percentage of who makes more, which of course are men. We know this and we have known this for a long time. So when we talk about health and when we talk about well-being and when we talk about rights, obviously it's not just talking about access and coverage. We are talking about a lot more. So health and well-being, positive peace, and because of internal conflicts, we cannot have peace, social and environmental justice, also and because of the problem of ecological threats and the issue of social justice, not everybody has access to everything. And when we cannot deal with social determinants, and I insist, for many years I teach the course on social determinants of health, and the other day I was thinking about how long I have been teaching, and it's been so long, many years, and one of the things that I cared about the most is the early child development. We were lucky enough to be part of the commission, and when we were talking about this, we were talking about early child development, but this has to become something that is embedded in our mindset. And of course, we don't realize sometimes about the importance. We need to promote universal health systems and obviously digital health. And so, of course, digital health for each country means a different thing. We are working very hard to have a basic package of basic consensus of what digital health means, because definitely we cannot keep on working without taking this reality into account. And of course, there's more priorities. Definitely there's more priorities, but what are the priorities? There has to be an ecological approach. Yes, ecological approach means that you need to have all of the levels. And there's ministries that still talk about life cycle, but it's course of life, and then social capital. What did the pandemic show? That there was no solidarity. That's what the pandemic showed. There was solidarity maybe between ourselves because we helped for community kitchens and community pots, but between the countries, there wasn't much solidarity. Vaccines started to arrive faster when they bought everything and there were some vaccines left. I'm sorry, but that was a reality, and that was a reality everywhere. So what are we talking about? We're talking about social network and cooperation and participation and reciprocity and solidarity, but especially and trust. It's especially trust. And I think this is one of the things that have been lost, trust. Not only among those who lead, but trust among and between us. Something else, system health, resilient and universal health systems. We all know that if we actually get all of the health services together in the world, we would be but nobody remembers that. And so when we start looking at the hospitals, we have quite successful experiences. We have 6 countries. We've had an exchange with Colombia, Peru. It was also mentioned by Jargas, and we have trained in order to measure, because you cannot improve something if you don't measure it, and you cannot define something if you don't have it in the public agenda. So something else that for us is basic is health at the center of the policies, at the core, at the center. So this is Horas Cono. And so we're saying that health has to be at the core of everything, because what happened in the past 3-4 years of pandemic, it was the time when, health needed to face economy or, treasury, and they were all talking about the same thing. But now it's not that. Now health has become again a completely different thing, because they don't believe that this is an investment. And then we should not forget boys, girls, and adolescents. When I'm talking about childhood and adolescence, I'm talking about since the conception, early childhood, childhood and adolescence. It is so important. It is very important to have neonatal care. But we all go to maternal and we forget about the first 28 days that are so important. And they say everything is important, but there's no doubt. I think that, we definitely are convinced that childhood and adolescence are not the future. They are the now. They are the present, because all of the actions that we do, they will actually then, become the future of the nations. So this is the numbers. I don't have any more time for anything. What do we do? Well, at Horas Conu, we have 52 years, and the heads are the ministers and the vice ministers as well. And so mainly the ministers. We have the 6 ministers. We have the Andean integration system. That means that we are still part of the integration system. How many people were? It's almost 170 million people. What is our vision? We already said this. Everybody enjoys how do we work? Well, this is our reference framework and the principles, approaches, and if you realize that the first one is human rights, these are our strategic lines for our work until 2030, and this is how we work. We have, and proudly so, I say it, I repeat it, and I emphasize this. These committees are made up by representatives, official representatives of all 6 countries. And this means that the Andean organization is not only the executive secretary, it is all of these with an official representativity. So when the committee, anything that is put out by the committees are done by the 6 countries. And in 2 weeks, we're going to present this topic in the World Nephrology Congress, because this is one of the few areas, and I think the only area that has an Andean policy on this regard. And as you know, chronic kidney disease is actually eating up a lot of budget around the world. So this is something important. Everything, you can look for it. We actually, have the policy on overweight, obesity, cancer. Now we're looking at childhood cancer. And, this is one of the things that was mentioned also by Dr. Jarvas. It's complete success, the, child cancer, because the numbers are improving and are getting better. And, if you have, I think the indicators are improving. And that is actually excellent. We work with everyone. We see, mechanisms of integration, cooperation agencies, other organizations, academia. We are working with a lot of people. And the idea is that we can keep on working together so that the right to health is a reality for everyone. Thank you very much. And together, I think we're stronger. I just want to thank those who helped in this contribution, Berta Pinedas, Ruby, Danitza, and Stephanie Tafur. Thank you very much.
Muchísimas gracias, doctora Calle, por su extraordinaria
Thank you.
presentación y dado el tiempo vamos a
Thank you
iniciar
very
el
much.
espacio de diálogo que es importantísimo, pero antes no olvidarnos que estamos transmitiendo también en vía
Do
virtual
not
para
forget that
todos
we are
los
broadcasting this live. Thank you for everyone. Thank you to
organizaciones
everyone who's
que
joining
están
us, officials of the Ministry of
en
Health, of the 6 ministries,
de otros países como México,
other
Nicaragua,
countries like Mexico,
Argentina,
Nicaragua,
República Dominicana,
Argentina, Dominican
Uruguay.
Republic, Uruguay, among others.
Para empezar este espacio,
So to
quisiera
start this
invitar a
Q&A, I would like to invite everyone here if you would like to ask a question, if you have a comment,
para luego dar
and then,
paso a los que nos
we are
han
going to
señalado
answer the questions that we got online.
compartiendo por vía virtual. Adelante, doctora Aníbal. Va a tener que acercarse, creo. Ahí está el micro, gracias.
Bien, muchas gracias.
Thank you very much for the invitation. Aníbal Velázquez, World Food Program. Thank you for the invitation, Dr. Calle, Mr. Vice Ministers, Dr. Malki. Thank you for this space. And of course, it's such an important day, which is the International World Health Day. And of course, the interesting is how you connect the rights to what the system is doing and what the countries are doing. The Andean countries, I think it's quite useful. I think a key aspect of the presentations has been to show the importance, that this is that the right to health has to be at the core of everything, and how the determinants can be aligned to this need. So just one comment. It is true. It is true, and we need to look for that's I think has always been a problem. Governance, multi-sectorial governance. I think this is an issue, but it is also important, what each sector does. What the system does is important because a lot of goals are directly from the health system. And I think part of our job is to see how to improve the efficiency and the efficacy of health management. But looking at these, provisions and benefits, it is important to think about this proposal of modernizing the system. You will still need resources, and so the discourse of being able to use economic arguments to mobilize resources is key. But also, once you get the resources, the Ministry of Finance says, well, if you spend it or not, and how efficiently you spend it. So it's always important to think about this. You need more resources, yes, but we also need to improve efficiency of, and that is part of the task. And the other one is prioritization. I think this is also important. Now, what was mentioned is, part of the 17 development goals and 169 objectives, and then in 2030, very soon now, we will have to show results because we need to advance. And so the evaluation of in the evaluation in 2015, actually Peru was the one with the highest performance in improving health indicators in 32 indicators, and it has been considered as the country that actually achieved the highest impact in reducing, not necessarily lowering, improving all the indicators, but actually it was the top country in reducing the indicators the most, or improving indicators the most. So I think the challenge is, how do we get there? And one of the objectives that we are worried about, is the SDG2, which has to do with malnourishment or stunting and hunger. And before the pandemic, it wasn't as big of a problem, but after the pandemic, now it is. So we need to look at how we're going to respond to that. And Anemia is a reflection of what is happening, really. It's just a reflection of what is happening. And so it is a concern, definitely, for sure. And it requires effective interventions to be able to reduce this. Something that we did with UNICEF was the community agents. I know that this year they have included more districts, and so I think this is the way that we need to work. But it doesn't really solve the problem of access to food, which is what you mentioned in your presentation, and that's why we think that the intervention, as Dr. Calle said, the fortified rice is a good solution, and it started out as a useful strategy, but it still needs to be universal, and it's not. We need the regulation. The law is there, but we need the enabling legislation or regulation for it to become universal. And the thing is that the experiences in Peru have been good, really, in terms of food. Peru has been the trailblazer in fortifying this salt with high iodine. And so this became universal around the world. And, definitely fortification of food Peru is one of the trailblazers, really. Another fortified food in Peru is flour with folic acid. And there now are impact studies showing that we actually have had an improvement in terms of folic acid. Let's do the same thing with iron. Rice is one of the things that are things that we consume the most. And it's not only iron, it's 10 micronutrients that at the same time help other systems in the body. So Con Gusto, which is a program, but definitely we are going to help in whatever is needed in organizing this kind of discussion meetings to be able to help for these regulation to come out. And then at the same time, I think that with Orasconu, we can work together, in this kind of information with the other countries. And I think that the food security should be on the list. Maybe we can have a committee just for that. It has to be, of course, a part of that. And so maybe we can include a food security committee. And that's just one proposal. And then, that's what we're here. We are here to help. Thank you very much.
Aníbal, ¿algún comentario de repente?
Solo sobre, ya se hizo el ofrecimiento y encantado de. Tenemos un problema con el tema de la fortificación del arroz en el nivel del MEF. Entonces, sí, a ver, nuevamente, entramos en una mesa técnica con el Ministerio de Economía y Finanzas y estamos en ese proceso ahora, pero un sustento en términos económicos sería más que contundente para ya inclinar la balanza hacia la universalización de la fortificación del arroz. De repente podemos conversar más adelante sobre eso.
Sí, sí. Ok, doctor, muchas gracias por los comentarios. Creo que estamos en la misma línea, ¿no? Veo por los argumentos económicos. Realmente es potente hablar con los argumentos económicos. El Ministerio de Economía, bueno, yo vengo del Seguro Integral de Salud, ¿no? Y entonces, cuando lo encuentro con 1.200 millones de soles y ahora tiene más de 2.000. Y el asunto es decirle, son economistas, decirles, tanto es la inversión, tanto es el retorno. ¿Cuántos se enferman menos? ¿Cuántos van a trabajar más? ¿Y cuántos van a crear riqueza? Y ahí tenemos otra tarea entre los países andinos, que es la tarea de volver el aseguramiento universal en salud a convertir en una seguridad social universal, que es otra cosa, pero es un escalón más. Ya tenemos una tarea, ahora viene la siguiente. Y eso es hablar con economía y hacer que el Estado ponga todos sus esfuerzos en la persona. Y es un cambio de concepción de cuál es el deber del Estado con el ciudadano. No es una tarea fácil, pero la vamos a hacer. Sobre la inseguridad alimentaria. No es posible, pues, que países andinos que han puesto alimentos en el espacio para que vayan los astronautas, hablando de la quinoa, cañigua, kiwicha, tengamos anemia. Y es una cuestión que tiene que ver mucho con educación y los otros sectores. Y también estamos trabajando. A nivel de viceministros es un trabajo un poco más técnico y el trabajo se convierte en técnico-político y el sustento técnico está ahí. Es la toma de decisiones lo que nos importa ahora y para esto los sistemas de información nuevamente. Porque tenemos que medir lo que estamos avanzando. Y obviamente al MEF, a Economía, se le va con números. Cuando tenía, como le decía, recibía el Seguro Integral con 1.200 millones y tenía una deuda no aclarada de 1.800 millones. Si iba al MEF a decirle, deme los 1.800 millones, que son un año y medio de presupuesto, no los iba a dar, pero fui con ideas. Es decir, ¿cómo invertimos en salud y cómo retorna en salud? Estuve en una conferencia con el doctor Pretel hace un par de semanas y yo a nombre del ministro, del Ministerio de Salud, le agradecí las cosas que había hecho no por el país, sino por el planeta, porque haber puesto el yodo en la sal significó que en el país no tengamos bocio, tengamos menos bocio y en el planeta también. Pero ¿qué está sucediendo? Si vemos los porcentajes de cómo el nivel de yodo está bajando en la sal, es alarmante. ¿Y qué quiere decir? Que vamos a regresar a tener probablemente bocio. Entonces, es tarea de todos, es tarea de agricultura, alimentación y sistemas de información. Cuánto nuestro bocio, cómo estamos trabajando en otros sectores. Entonces, en el Perú hemos hecho muchas cosas, completamente de acuerdo, pero no solo en el Perú, en los países andinos, ahora que estamos con una audiencia internacional. Pero el éxito de nuestro pasado no nos garantiza el éxito del futuro. Tenemos que hacerle mantenimiento, haber hecho, no sé, como decía, Machu Picchu, la línea de Nazca, Chan Chan. Eso no nos garantiza el futuro. El futuro lo tenemos que construir ahora. Gracias, doctor, por su reflexión.
Gracias, señores viceministros. La doctora Marta Rondón, por favor, pidió la palabra. Gracias. Muy buenas tardes. Muchas gracias por haberme permitido estar presencialmente. Ha sido muy refrescante escuchar al doctor Sánchez hablar de ese afronte multisectorial para el manejo de anemia y de dengue. Creo que es la única manera como vamos a poder hacerlo, porque eso de estar repartiendo sobrecitos con fierro, visto desde afuera, como locura. Y eso me permite hablar luego de cómo luchar contra la anemia es una acción que repercutirá directamente sobre la salud mental de fetos, niños, niñas y adolescentes. Y eso nos pone en el tema moderno, pero que ya tiene muchas publicaciones en el World Psychiatry, en el Lancet y otras revistas de prestigio, de cómo estamos aprendiendo que en salud mental se puede hacer prevención primaria, que así como no mejoramos la salud, la anemia repartiendo sobrecitos de fierro, tampoco se va a mejorar la salud mental en el mundo dando mayor acceso a los antidepresivos. Esa es una acción de prevención secundaria. Pero la prevención primaria está en atender y realizar intervenciones significativas en dos periodos, el perinatal y la adolescencia. Y creo que en el periodo perinatal, mejorar la nutrición de las madres, es decir, reducir la anemia de la madre, de la mujer gestante, y reducir la anemia de los menores de 4 años, son acciones muy significativas cuyo resultado sobre la salud cerebral se van a reflejar directamente en una mejor salud mental. Sin embargo, creo que también tenemos que tener el mismo tipo de afronte clarísimo para
ver cómo disminuimos el flagelo de la violencia contra las mujeres, que tiene un efecto directo, por ejemplo, sobre la seguridad alimentaria. Las mujeres que sufren violencia tienen más posibilidades de sufrir inseguridad alimentaria y todo su correlato. Finalmente, si me permiten, me ha preocupado escuchar decir que los derechos de la salud están relacionados con deberes. Los derechos de la salud son independientes en sí mismos, no pueden ser cuestionados por nada. El autocuidado es hijo del derecho a la información en salud, que es es parte del derecho a la salud. Gracias.
Bueno, voy a empezar por lo último que acaba de decir. No es que el deber elimine el derecho. El derecho elimina, y para esto tendríamos que discutir todo lo que se ha discutido sobre derecho a la salud, si debe o no estar en las constituciones. Al inicio de la reunión dijeron que una gran proporción estaba en la Constitución. Y ahora tenemos que hablar también de derecho efectivo a la salud. Y ese derecho efectivo a la salud tiene que ver con educación. Y alguien que está educado sabe que tiene que alimentarse bien y sabe que tiene que tener deberes consigo mismo. Por eso decía, no separar la parte de corresponsabilidades y autocuidado. Porque sin participación ciudadana no hay derecho a la salud. O sea, el derecho a la salud implica otros derechos, no viene solo. Entonces, uno de esos derechos es el derecho a la educación. Y una reflexión muy importante sobre las constituciones. La doctora ha mostrado cómo están de diferente manera. Son las mismas palabras, pero significan distinto. Si vemos la constitución brasilera, que es muy clara y dice, la salud es un derecho y el Estado la garantiza. Vemos la constitución ecuatoriana y boliviana, son muy parecidas, pero hay otras constituciones que dice, el Estado promueve el cuidado. No, es diferente decir una garantía, son diferentes palabras. Pero es tarea que tenemos ahora la generación gobernante, es que la salud debe estar en lo máximo de la pirámide normativa de Casey, ¿no? Entonces, y la salud no debe dirimirse en los tribunales. O sea, no debemos tener a la salud como derecho por una sentencia judicial o una sentencia del ente judicial. Sobre mujeres y violencia, obviamente. Una de las inequidades más grandes es el género, pero tenemos que verlo integralmente como familia y comunidad, porque donde una mujer es violentada, hay un niño que sufre y hay una familia que tiene menos salud. Entonces, cuando hablamos de reducir las inequidades, tenemos que reducir todas las inequidades, la de género, la racial, la económica, la de educación, y en nuestros países que son tan diversos, la territorial. O sea, porque no es lo mismo vivir en los Andes, en la Amazonía o en la costa y menos en una capital. Eh, Respecto a lo que acaban de decir. Gracias.
Yo quería hacer un comentario chiquitito. Estuve el año pasado en una reunión en Ginebra acerca de medicina en las personas. Entonces estuve con los top del mundo, ¿no? Todos los professors del mundo. Y el tema era pues, ¿no? El autocuidado y la corresponsabilidad. Y cuando yo planteé cómo era América Latina y cómo eran nuestros países, no lo podían creer, muchos de ellos, ¿no? ¿De verdad, Mari Carmen, no hay agua a las 24 horas? Sí, le digo, hay sitios donde no hay agua. De verdad que no sé qué. Entonces, ¿cuál es mi comentario? ¿A qué viene este comentario? Yo puedo cuidarme, pero existen condiciones básicas que debo tener para cuidarme. Era realmente gracioso, disculpen la palabra, cuando nos decían lávense las manos, lávense las manos, lávense las manos, y habían sitios donde no había agua, ¿no? Era gracioso cuando nos decían aíslen, aíslen, y habían casas donde vivían 6 personas en un dormitorio. Me dejo entender. Entonces, yo creo en yo no le digo deberes, es una, soy especialista en adolescentes, pues jamás le voy a decir deberes a los chicos, ¿no? Porque simplemente van a decir no. Yo les digo responsabilidades. Hay responsabilidades, pero la torta está bien dividida. No solo son responsabilidades individuales, hay responsabilidades de los estados, no, todo el mundo tiene su pedacito en este asunto. Entonces, uno no puede exigir el autocuidado cuando no se tiene con lo básico resuelto. Y ahí es que hablamos de salud, educación y protección social. Tema concreto, lo puse en una de las presentaciones. ¿Cuántos huérfanos tenemos de COVID? ¿Sí o no? ¿A cuántos huérfanos estamos llegando con ese bono de 200 soles? No sé. ¿A cuántos huérfanos estamos llegando con la intervención de salud mental? No sé, me dejo entender. Y ese es el tema de equidad. Uno tiene que llegar a los que más lo necesiten. Porque ¿qué sucede a veces? Que nuestros programas llegan no necesariamente a los que más lo necesitan. Entonces, yo creo que este tema de deberes, responsabilidades, autocuidado, corresponsabilidad, tiene matices diferentes según de dónde partimos. Es como la meritocracia. Siendo hijo de la universidad más importante y haciendo una carrera académica, y otra cosa es partir habiendo venido de un sitio donde no había nada y yo llegué a tal sitio, ¿no? Yo creo que tenemos que tener, digamos, a las personas no las podemos tratar igual, porque las personas son diferentes y cada contexto es diferente. Pero de lo que sí estoy segura es que tenemos que trabajar para que todos tengan las mejores condiciones posibles. Eso es derecho a la salud. Que yo nazca no pesando menos de 2,500, salvo que tenga una enfermedad rara o tenga otro, ¿no? Que yo, cuando nazca, me atiendan y no entre en una asfixia. Y si tengo asfixia, que es el 10%, me sepan resucitar. Si salgo prematuro, me dejo entender. Esa es la idea, ¿no? La idea es que todos, sin excepción, tenemos derecho a eso. Entonces, creo que ese es, y perdonen que me estoy extendiendo, me van a matar, ahí nomás. Ya.
Muchas gracias. Gracias. Creo que va a ser la última de la sala, el doctor
Cabezas del Instituto Nacional de Salud.
Sí,
Nacional. Adelante.
sí, muchas gracias por la invitación y congratulaciones por este evento. Creo que es muy enriquecedor, sobre todo cuando están presentes los decisores. Y solo quería comentar de que la pandemia nos ha mostrado lo que se ha mencionado, ¿no? La falta de solidaridad entre los países del mundo y las brechas tecnológicas que hay entre los hemisferios norte y sur, ¿no? Y tenemos problemas comunes los países, además de los países andinos, los países de la región, ¿no? Por ejemplo, el tema del dengue, cada vez desde el 90, cada año hay más que el año anterior y es común a nuestros países. Y tenemos este problema crónico también de la anemia y la malnutrición, diría, ¿no? Porque la obesidad también está disparándose. Entonces, ¿qué hacemos para afrontar de manera conjunta como región estos problemas? ¿Y cuál sería la interacción que tiene, por ejemplo, el grupo andino con los otros países como Brasil para retomar lo que antes se ha hecho, ¿no? Eran otros tiempos, había menos gente, menos urbanización, menos velocidad en la migración, que se ha logrado erradicar la viruela, se logró erradicar el Aedes aegypti en las Américas en los años 50, y ha sido una acción conjunta de los países, ¿no? Porque la parte geográfica, ecológica, hace que no nos podemos separar, por ejemplo, de los países amazónicos. Y los andinos en realidad casi todos son amazónicos también, excepto Chile. Entonces, un poco la idea es cómo afrontar de manera conjunta y teniendo en cuenta que es así posible en otros tiempos, ¿no? Y creo que las ODS son un buen norte. Sin embargo, el año 30 ya está acá nomás en la vuelta de la esquina y va a tener que hacer, y creo que es una oportunidad para evaluar y orientarnos hacia el futuro, porque la pandemia también nos ha mostrado de que el objetivo 3 de salud y bienestar depende de los otros 17, 16 objetivos que creo que es un sueño y creo que el reto es implementarlo. Gracias.
Yo quería contestar, nosotros trabajamos con OTCA, que es el tratado amazónico en el que están 8 países. Trabajamos con Mercosur, ¿no? Que está al sur. Y nosotros que somos los andinos. Y también tenemos un trabajo muy cercano con Secomisca, que es Centroamérica y República Dominicana. Tuvimos una experiencia muy buena el año pasado. Estuvimos en Brasil, en Sao Paulo, ¿no? En Brasilia, con un foro muy grande de no transmisibles. Y estuvimos presentes toditos los mecanismos de integración y también presentes todos los ministerios. Y realmente en estos pocos meses que han pasado, muchas cosas compartidas ahí han sido absorbidas, ¿no? Porque, ¿cuál es la idea? La idea es en estos espacios, es intercambiar experiencias y aprender, adaptar ¿no? Y por otro lado, tenemos el tema de los institutos nacionales de salud, ¿no? Que tú estás ahí, que tenemos los 6 institutos andinos y que la experiencia más gratificante ha sido la experiencia de Bolivia. Bolivia en unos meses con el proyecto que lidera, ¿no? Ahí está Walter. Walter Vigo, digamos, de vigilancia genómica, Bolivia, que no tenía un montón de cosas, ahora las tiene, ¿no? Porque la idea de la cooperación andina es como dice Naciones Unidas, no dejar a nadie atrás, ¿no? Y definitivamente las áreas son distintas. Hay áreas en las que hay países que están más desarrollados que otros, pero hay otras áreas en las que los que no están desarrollados en las otras sí lo están. Ahora, Brasil. Con Brasil estamos en todo este tema de vacunas, ¿no? De poder capacitarnos, porque yo creo que todos estamos apostando por soberanía sanitaria. Queremos en algún momento, un país no lo producirá, pero si nos juntamos. Y otro tema que en este momento es prioritario es negociación de precios. Estamos viendo la negociación de precios con 2 temas muy importantes que son hepatitis C y los oncológicos. Me llama mucho la atención, ningún país puso vacunas, así que ¿será que los países tienen mucho dinero para pagar las vacunas? No lo sé, pero lo concreto que no lo pusieron como prioritario y sabemos muy bien que en vacunas se gasta muchísimo dinero. Pero bueno, estamos comenzando con la negociación de precios. Ahora, soy sincera, César, se avanza lento. ¿Por qué? Porque los procesos nacionales son distintos y para poder llegar a consensos no es tan fácil. Y ahí quiero hablar de otro tema, ¿no? Que acá decía Ciro, multisectorialidad, transsectorialidad y todas las sectorialidades. Estoy de acuerdo con eso, pero hay un problema muy grande en los ministerios. Disculpen, lo voy a decir, que es la compartamentalización. Uno va al ministerio y no, yo solo me indico, y en los 6 nadie se libra. Bueno, en las últimas reuniones de autoridades nacionales de salud, con mucho orgullo, debo decir, no se molesten los otros países, por favor. Con mucho orgullo debo decir que uno de los países que va una sola persona a presentar todo es Perú. Pero los otros países, todos los países llevan cada dirección va y cuenta lo que pasa. Yo no sé si estará mejorando la compartimentalización del Ministerio de Salud de Perú, pero ese es un tema muy, muy importante en el momento de tomar decisiones. Es muy importante, porque la gente que trabaja a ese nivel tiene que tener una idea clara de qué está pasando alrededor, no solamente del sitio, del área donde está, ¿no? Porque el tema, necesitamos algo integrado. No sé, no le voy a dar oportunidad para que hable. Ya no.
No sé.
Algo chiquito nada más porque la pregunta del doctor Cabezas es sumamente importante. Es necesario apelar a las alianzas regionales porque, por ejemplo, en la última reunión del Comité Ejecutivo de la OMS se entendía que iban a ya arribar a resultados sobre el tratado pandémico. Y a juicio de lo que pude conversar, no solamente con los heads de OMS, de PAHO y de los países, ¿ah? Porque yo he conversado con los representantes de Estados Unidos y de países del hemisferio norte, como dijo el doctor. Y es muy poco probable que se lleguen a acuerdos vinculantes, ¿ah? Es material, es muy poco probable, yo diría imposible. Por lo que apelar a alianzas regionales va a ser, creo, una opción de poder fortalecer la posición de un conjunto de países en aras de poder tener acceso mucho más apropiado a las contramedidas y las respuestas frente a las amenazas globales. Dicho sea de paso, el Ministerio de Salud ahorita estamos trabajando ya el cierre de brechas de las competencias del Reglamento Sanitario Internacional. Hemos terminado el SPAR. Vamos a ir por la evaluación externa voluntaria y esto nos va a generar el plan, ya un plan y una hoja de ruta para cerrar brechas. Hay una oportunidad, por ejemplo, estamos implementando una ley que va a permitir a la Red Nacional de Epidemiología constituirse como un verdadero punto de enlace con injerencias sobre los puntos de entrada, etcétera, etcétera. Y eso estamos trabajando intensamente ahora en aras de fortalecernos como país para lidiar mejor o responder mejor a las amenazas globales. No digo nada más.
Sí. Bueno, doctor Cabezas, siempre es un gusto escucharlo y sus sugerencias, tomarlas, ¿no? Bueno, sobre independencia tecnológica, prepandemia y pospandemia. Los países andinos hemos avanzado muy poco. Comparémonos, por ejemplo, con los países asiáticos. Comenzaron con un 60%, terminaron con un 100% de soberanía tecnológica para afrontar una nueva pandemia. Entonces, sí tenemos una tarea grande ahí, que es también en la toma de decisiones, también que la compartimos con la academia y la investigación, que nuestros modelos en los países son distintos. Después voy a aprovechar también algo muy importante que ha dicho el doctor Aníbal, y es sobre el agente comunitario en salud. Nuestros países andinos tienen que, la primera línea de batalla son los agentes comunitarios, en las zonas más desfavorecidas. Y sí tenemos que trabajar en algo diferente, porque ya el voluntariado está cada vez terminando, pues. O sea, y otra cosa es, estos agentes comunitarios, al ser nuestra primera línea de defensa en salud, le tomo la palabra, es decir, la solución no está en el sobrecito para la anemia, ni en darle una pastilla. No, es nuestra primera línea, enseñar a comer bien, comer mejor, porque en varias zonas, hablando de Perú, ha bajado la desnutrición, pero ha aumentado la anemia. ¿Qué quiere decir? Que están comiendo más, pero entonces es una cuestión de educación personalizada. Por eso ponía entre los retos personalizar la salud a nivel local. Y lo mismo, el agente comunitario, bajar el tratamiento o las acciones de salud mental, evitar menos psiquiatras y más felicidad al nivel territorial local. ¿Ah? Gracias.
Muchísimas gracias. Yo sé que el tema da para muchísimo más. Estamos muy motivados, sobre todo cuando es un tema presencial, híbrido en realidad, y tenemos que agradecer muchísimo a todas las preguntas que hemos ido recibiendo desde la vía virtual, que lamentablemente no vamos a alcanzar a responderlas, pero ya las vamos a considerar. Algunas han sido respondidas durante el... Y ya para ir cerrando este espacio y ya ir finalizando este evento, voy a pedirles un mensaje final a cada uno de nuestros ponentes. En un minuto, su mensaje final. Empezamos con el doctor Abel. Ciro Abel Mestas.
Bueno, estando en un foro multinacional, creo que también es importante tener un comité de salud digital y salud transfronteriza, porque estamos en países donde las fronteras realmente no existen. Somos andinos, veamos, coordinamos con Bolivia, por ejemplo, al momento se vuelven en salud también ventajas. Personas que estaban en la triple frontera Perú, Chile y Bolivia se habían vacunado más rápido con sus 3 dosis. Entonces se convirtió en una ventaja porque en cada subsistema se vacunaban. Entonces, es un reto para nuestros países, dos cosas, ¿no? Salud transfronteriza y salud digital. Muchas gracias.
Sí, bien, primero quiero agradecer la invitación de Loras y bueno, el mensaje final para los países andinos que están conectados y al público que nos acompaña, la importancia de la reflexión que tenemos que hacer en el Día Mundial de la Salud, que la salud es un derecho y que para esto, como ustedes se han dado cuenta, existe toda una constelación de factores que tienen que ver con poder llevar a cabo y poner en práctica concretamente y realmente en nuestras poblaciones. Y creo que un catalizador para poder atender a toda esa necesidad tiene que ver precisamente con la integración. La integración andina es uno de los espacios más importantes que puede darnos esa oportunidad de compartir experiencias y precisamente integrarnos para poder avanzar en ese propósito.
Reiteramos nuestro agradecimiento a nuestros conferencistas por excelentes ponencias y reflexiones que hemos tenido el día de hoy. Hemos recibido muchísimas felicitaciones para cada uno de ustedes por la vía web. También nuestro agradecimiento a todos los participantes que en esta ocasión han estado también presencialmente, al equipo de Loras Cono, especialmente a nuestro equipo técnico, a Rob, Yadira, a Ruby, Janet y Elsa, ¿no? Por todo el apoyo brindado, a todas las personas que están participando en esta actividad que han hecho posible, gracias al compromiso con la integración andina y latinoamericana. Ya para el cierre final, voy a dar la palabra a la doctora María del Carmen Calle del evento. Adelante.
Sí, porque a mí no me han agradecido la exposición. Se saltaron, pero bueno, no importa. Muchísimas gracias por la presencia. Yo creo que hay un dicho que dice, si todos hacemos las cosas bien, las cosas salen bien. Todos acá, todos los presentes y todos los que están conectados, tenemos algún tipo de deber, responsabilidad mejor, responsabilidad, y tratemos de hacerla lo mejor posible. Sitio del escenario estemos, ¿no? Porque uno va cambiando de sitio en el escenario, pero yo creo que todos tenemos en común que no hay ninguna duda hecho a la salud de convertirse en algo real y tangible, ¿no? Es decir, que se manifieste en los momentos que más lo necesitamos, ¿no? Que si yo tengo un accidente, no tengan que preguntar, ¿y usted tiene seguro o no tiene seguro? Para ver si me atienden o no, sí o no, ¿no? Si yo tengo necesidad de tener un tratamiento oncológico, no tengo que buscar si tengo si tengo salud o si tengo oncosalud, sino que realmente se vuelva real, ¿no? Que realmente lo podamos ejercer. Pero antes de solo hablar de servicios, tenemos que pensar en las condiciones básicas para una vida digna, porque yo creo que todos merecemos una vida digna. Muchísimas gracias por estar con nosotros y bueno, nos vemos el siguiente jueves, pero solamente por vía virtual. Esto de una manera excepcional hemos querido celebrar el Día Mundial de la Salud. Mi salud, mi derecho. Agradezco formalmente al doctor Jarbas Barbosa, que fue el primero que inició las presentaciones, al doctor Ciro Mestas, al doctor Eric Peña y a todos los presentes en esta reunión. Muchísimas gracias. Así es.